What advice do you guys have for new people in your roles, new EKG techs, new scribes? I mean, we've kind of covered that with burnout a little bit, but somebody brand new to the role.
I say if you are stressed, take a deep breath, especially in situations where you have stat orders stacked and then the stickers or the leads are not staying on the patient, so you have to fix that, and then you're just sweating. You're like, oh my gosh, I need to grab the other EKGs and all that. I say stay calm, take a deep breath. You'll get your EKGs and get the outcomes you want if you are calm.
Mm-hmm. One of the biggest things that I tell new patients, new hires, and I've told this with you before when I was training her a little bit, is just be confident in yourself. Mm-hmm. Okay? Don't be overconfident, but trust your knowledge, because you are a lot smarter than you think you are, right? If I am testing new hires or interns and stuff like that, giving them a little bit of a class and be like, what is this? And it's like sinus rhythm, right? And they're like, oh, I think it's like PAC. Like, they're overthinking it, right? Mm. And then if that happens with just a basic rhythm, I can't imagine what it would be for an actual emergent, like EKG, like SVT or STEMI or a block, right? So some people don't like it, but like at the end of the day, I'm trying to help that individual out. I'm trying to help you guys out, build your confidence, and it does take time. I know that I can be a little bit pushy with that kind of stuff, but I want to make sure that you guys are confident enough when you're by yourself, right? And and that comes with me too. Like, I try to be humble. I don't want to be overconfident and be like, oh, I know everything, right? Because that's just going to bite me in the butt too. Yeah.
I say with the newer generation too, it is a good thing to ask for help. Mm-hmm. If you're really struggling, ask for help. It is not. You should not be scared to ask for help.
I ask for help
all the time.
I've been doing this for a while, and if I'm not too sure how to work something out, I will ask for help. There has been times since I have been in non-invasive a little bit longer than them. I tend to do a little bit more of the IT side of things, trying to figure those things out. But if you're not sure about something, just ask.
I see that with even APPs and doctors. When a patient they're really like not sure about and their symptoms, you guys always go after doctors for help. So
nobody comes out of school, regardless of what your role is or whatever your training was. Nobody comes out knowing everything. Yeah. And I feel like the longer you do this, you realize the less you actually know. And that's something new PAs struggle with too. Is like, when do I need to get a doctor involved? And if you're questioning it, you probably should get a doctor involved. But it's a hard concept to like really wrap your mind around. Like, you want to be confident, but you need to know those patients that need to see an ER physician, and you need to know the patients that don't need to see an ER physician. And that's a hard line to figure out, especially when you're new. You're not aware of your own limits.
Again, it depends on the type of physician that you're talking with. But there has been times where like I was getting an EKG and the doctor thinks that it was one thing, but it's not. You're not going out of bounds to be like, do you think it might be this instead? And there was one time it was one of the coolest strips that I've grabbed was I had a provider that was thinking that it was SVT, bouts of SVT going in and out. And I grabbed it and I was like, I think he's going in and out of both SVT and VTAC. So then I went up to the provider and I was just like, I think that this is VTAC. And they're like, what? It's a little, on the thinner side. And I was just like, well, voltage is a little smaller. There's low voltage and the morphology is a little bit different. And I told him, I was just like, put in another order and I'll try to capture both of them on one strip. And I was able to get both the VTAC and the SVT in one strip.
Really
and
cool.
Then it was just like, oh, like, I'll be damned. Like, it's not, you can always be like, I think it might be this. What are your thoughts?
Mm-hmm.
And you're advocating for the patient, which I think is an important thing to understand, that you shouldn't be afraid to bring up your concerns, regardless of your role, nurse, EMT, EKG tech. Like, you shouldn't be afraid to bring up your concerns if you're seeing something, because you're just advocating for the patient.
Right.
Yep.
Worst case scenario, you're wrong and the physician's not worried about it. But best case scenario, there's something for the patient that matters that you've now caught because you were willing to actually speak up. And I think a lot of people are afraid to. New nurses are dealing with the same thing. They're often afraid to bring up their concern, but it's like, if you were at the bedside for a half an hour as the nurse, you saw a lot more of this patient than I did. So I try to take that stuff seriously when they're brave enough to bring up a concern that may or may not be anything. It's like, okay, I'll go take another look at this patient now that you've brought this concern to me. And usually things get caught that way. You know, if you blow off the nurse every time she comes up and says, hey, this patient's looking way worse than when you saw him. If I'm like, no, they're fine, their vitals are fine, we could miss something important versus, you know, I need to stand up, quit doing whatever I'm doing and go reevaluate the patient. You're like, oh, they do look way worse. We need to escalate things that we're doing. So things get caught that way. I think that's important.
Yeah.
And you got to feel like part of the team, I think, in order to be willing to speak up. And part of that's on the providers. I feel like, too, we need to have an affect that's approachable. And if you're a very unapproachable individual, eventually that's probably going to lead to harm for your patients.
There's definitely providers or doctors out there specifically that I don't want to approach. I'm like, does this look like this or that sort of EKG? And then there's other providers I do ask, like, can you tell me about this? And yeah.
I try to tell this to a lot of the new hires, and I think that there's a lot of that misconception of like, oh, we're just grabbing the EKG, right? But like, I tell new hires, I was just like, this EKG, you might be able to, this might be the deciding factor of whether this patient lives or not, right? About a month ago, there was one EKG that I grabbed, and you don't really see it all the time, but the patient was going in and out of a right bundle. And that's kind of an indication that it does meet a little bit of protocol of getting a PCI. So I notified the doctor, and then I got it in the EKG. But even if I didn't capture it, it's also up to you looking at the EKG and interpreting and be like, hey, like this patient is going in and out of a right bundle, right? They're kind of going in and out. And it turns out that based off of the signs, they kind of looked up a little bit deeper, and then they called cath lab. She got cath, and she got 2 stents.
Wow.
Yeah. So there was like a 90% occlusion. Wow. And like, if that was missed, it probably would have gotten much worse.
Right.
Yeah. So like, and it's weird because she didn't have chest pain at the moment. She was having shortness of breath and abdominal pain. And, you know, as just a regular tech, just given that small little bit of information, went from like an anxiety attack to, oh, you're having a heart attack.
Yeah.
Right? Troponins went up, they got a trope, and then it was high, so then they got a cath.
Yeah. And again, like you're watching that rhythm while you're doing the EKG, often longer than maybe the provider sitting there staring at the monitor, and things like that can get missed. If I'm looking at the monitor for 3 seconds, I'm like, oh, they're just in a normal rhythm. They're narrow QRS. They're not going in and out of anything. But you're like, no, I just sat there and I watched this for, you know, a couple minutes while I was getting their EKG. There's something else going on.
It does sound kind of strange, but we are the specialists when it comes to that in the ER. When it comes to rhythm interpretation, we are the first steps, and then cardiology and ultrasound. Then they're the next guys. But we are the deciding indicators of like what's going to happen to this patient next. Right. So I try to tell like new hires, again, like be confident in yourself, but like at the end of the day, like your EKG determines what happens next with this patient's life, right? Yep. What's going to happen with them next?
Yeah, the treatment they get.
Yeah. So that gives them like a sense of like, oh, I do have a job rather than just collecting EKGs and just giving it to them.
It's very important.
It is very important to kind of notify and being confident in yourself.
Yeah, that and just like you are a team. You're part of a team. Mm-hmm. So you do matter.
Yep, 100%. Yeah, I mean, that's evident in some of these subtle things that a provider may or may not catch because they're not spending as much time looking at the EKG as you guys are, or, you know, just because you're sitting there and you see the rhythm strip for so long before you push that button to capture the 12 lead, and a lot of times things are missed because it's 10 seconds of what their heart's doing, what's it doing the rest of the time they're in the ER.
Yep.
Is there anything else you guys wish that the nurses and doctors or other people knew about your roles that you think they don't know? Anything else about scribing?
I think sometimes what they don't know, especially for night shift, is that we do have to fill the whole hospital. A lot of the nurses don't know that, so they call a lot for the EKGs. Scribing, other than an intake, super track is not as intense. So not so much with scribing. But
I think we're pretty well aware of what you guys do for the most part. I mean, we're reading your notes, and one point you brought up earlier that I think is good to reiterate is like when you're getting a whole bunch of EKG orders, they're stacking up. It's like you can only do one thing at a time. Yeah. And that's true like as a provider too. It's like if I've got a whole board full of patients, it's easy to get overwhelmed by like there's 1,000 things I need to do. There's a bunch of people I need to go see. There's a bunch of people I need to discharge. But you can only do one thing at a time. And if you're focused on this whole scope of work, it can be overwhelming. But you can only do one EKG at a time. And so if you just focus on
and I think that's where
task,
scribing and EKG flip-flop, because with scribing you do have to focus on a lot of stuff all at once. And I want to say out of all the jobs I did have, scribing was the most mentally exhausting job. I get out of my shift and I'm like, oh my gosh, what just happened with my day? Because it is very fast-paced, depending on the day, of course, but most of the time it is fast-paced, and you are seeing, with the doc, 90-plus patients, and you have to memorize everything the doctor says, everything the patient says, and you have to put in the chart, and it is a lot.
Yeah, and you're probably writing a full note for maybe 25 of those 90 people.
Because we do have to discharge whatever you guys discharge, which is about 10-plus.
Yeah. And you're finishing that long note while you're actively seeing new patients. You're trying to finish notes while you're getting new histories on patients. Yeah, I could see why that'd be overwhelming.
We're not able to step aside and finish the note or catch up. We just have to keep going with you guys. Yeah.
I think one of the biggest things is that I might get a little bit of heat for this, but is a lot of the times nurses, and they have their own scope of practice that they need to do, but just basic rhythm interpretation, basic things. And at the end of the day, that's what you need to do. You don't know, get evidence for it, get the EKG. But then I would come in and like they'd be like, this patient I think is having AFib, and I come in and I'm just like, oh, these are PACs.
Yeah, or sinus arrhythmia.
Or sinus arrhythmia. But in my thought, I'm just like, I don't want to sound like a dick, but like I want to be like, I'm like, you went to school for this, right? Or they'll come in and be like, this patient's tachycardic, please come in, and they put in a stat EKG, and I'm like, okay, well, I have to go all the way across the hospital to go get this one, and I come in and the patient's like 102.
Right.
But that I understand, I get it. That's what they're told to do, and it is at the end of the day, it's an EKG. Take you 3 minutes to do the EKG, right? But it can be a little bit frustrating sometimes when you have 5 people that are doing that, right? Mm-hmm. And you try to think of the positive things and be like, they're just doing their job,
right?
But like, you're like, I would come in and they're like, they went into this really weird arrhythmia, and they went up to like in the 120s and throwing a lot of PACs, and I was just like, okay. And then I walk in and the patient's walking out of the bathroom, and I'm like, was he pooping? And then he was just like, yeah, he just got done with the bathroom. And I was like, might be some vagal movements there that might be causing that, but we'll get it. And then I come in and it's completely normal again. Right. So like, it's the little things, right? And again, like I've been doing this for a while. Have some insight from rehab about like what patients' hearts do whenever they start breathing or hold their breath. That's why whenever I do the EKG, I tell them not to hold their breath. Mm-hmm. I tell them to breathe normally. Let's get that regular baseline.
Well, I will say, like, medical education, like 12 leads are so complicated. There's so many, like, minute details you can catch on a 12 lead EKG, and that's why like having the paramedic background like really reiterates that. Like that's a lot of what you do in paramedic school is like you can't get labs. We can check only a few things in the field on a patient, so the most you can glean from a 12 lead EKG the better. Like electrolyte abnormalities, if they have COPD, you can see reflections of that on what their heart's doing. And so I feel like as a paramedic I have a lot more respect for the 12 lead EKG and how complex that is. And then I look at how much education I got in PA school to read a 12 lead, and it's very limited.
Yeah, very little.
They go over it, but not nearly as in depth as you could go into.
Yeah, and even with us, because a typical thing is like we don't really deal with pediatric patients
mm-hmm.
that
as
often.
Much, yeah.
Right, but their rhythms are totally different versus what you would see in an old man.
Mm-hmm.
And
it's a lot harder to set them up.
Yeah. It is, especially your
newborns.
Your infants are, because they're 15 lead, not a 12 lead.
Yeah.
So they
and usually when they are newborn, they have that the mucus on them still, so the stickers won't stick on them as well. So it's like a 2-person job. You need someone to help hold some leads, and the other person holds the other leads while pressing the button. It's very hard.
I think one of my worst ones was, oh man, this is going to be kind of sad, but it was twins that were born early. I think it was like 6 months into the pregnancy. They were born that early. Like, I had to do an EKG on one of the twins, and it was like the size of my palm.
Oh my gosh.
That was hard. I had to cut the EKGs like in quarters, like the electrodes in quarters, and that one was a really tough one, and his EKG did not look good. But understanding those pediatric or younger audience. Once in a while, I go to the Air Force Academy, and I also do I medically screen the incoming Air Force Academy cadets, and like, you'll see them, their EKGs are out of whack. You know, they've been running around. They're in altitude. Yeah, a bunch of these kids are from like sea level,
right,
from the and all that kind of stuff. They're running around, not drinking, so their electrolytes are out of whack. They're always in sinus arrhythmia, but like, typically if you see that in the hospital, like, you would be like, oh well, this is a little strange, like, let's get this fixed. But like there are some people that need to understand, like, there are totally different types of EKGs out there. Right. Everybody's a little bit different.
Mm-hmm.
Yeah, gosh, doing them on like neonates, I can't even imagine that. I didn't even know they needed a 15 lead. I wouldn't even know how to interpret that. And
that one was crazy. I've done a couple of EKGs, and at the end of the day, they're like, what do you see? What do you interpret? And I was just like, well, I can't really give you a specific answer, because this is happening, and cardiology can't see it because they don't deal with pediatric patients. And I feel bad when I have to say that, because like, they're like, should we just give it to cardiology? And I was just like, I don't think they'll know what to do with it.
Yeah, it's probably the neonate doc that really,
exactly.
I don't know anything about that stuff, but it's got to be the neonate doc, I guess, that probably looks at that with more knowledge.
Yeah. And there are times where, like, and not all of them know really everything, like the cardiologist. I was kind of curious about, like, why do we put it on the right side, and what's the reasoning behind that when we do pediatric patients. And it turns out that it has to do with a little bit of pulmonary hypotension. A little bit of the right side is a little bit more developed, and if there is an issue with that kind of stuff, we can kind of figure out some things with pediatric patients, because I know that that's a really big thing with pulmonary hypertension with peds. So that's why they tend to look on that side. I didn't know about that, but when I asked like 2 cardiologists that, and they're like, I don't know.
Yeah, that's way beyond my scope.
Yeah, I had to ask like a peds doc.
Well, even within cardiology, there's specialists. You know, I mean, you have the EP doc that deal with all the dysrhythmias, and you've got the cardiologist and the ones that cath, you know, more often than other ones. Some of them don't do catheterizations, and some of them do a lot of them. And so, I mean, even within cardiology, there's so many specifics, you know, and specialists. One person does not know it all. That's for sure.
It's too much to know it all.
Oh, I think that's the beauty of cardiology, is because, like, there are so many different things. Have you seen an open heart procedure before?
No,
I haven't either.
That's wild. That's some crazy stuff. I got to sit in for a bypass one time, and the way that they open up that, to get first of all, to have the LVAD pumping out the heart. I forgot what it was called. What is it called when you're when they're circulating the blood? There's a perfusionist. I think it's a perfusionist, right?
I don't know.
That job would be really cool too. But yeah, their hearts not moving. So the thing is moving.
Yeah, it's just continuously.
It's like a VAD. It's an LVAD, pretty much.
And they don't have a blood pressure.
No, they don't.
I know some of the nurses will send their nursing students in to take a blood pressure on those patients because they know if they come back with a number, they're just making up a blood pressure because they don't have one.
You got to get a map when it comes to LVADs, and you got to use a Doppler and all that kind of stuff. And I would hope that they teach you those kind of things at school, but when I was in rehab, we would get LVAD patients, and I had to like look at like the whole protocol of like all the LVADs. If they're over a certain rate, you better call that team. Yeah, you better hurry.
LVAD patients are their own thing. And most people don't really have a good idea of how to deal with those patients. I think I can't even remember the last one I had, but a lot of that's phone calls to Denver to figure out what do we do.
I had to grab an LVAD blood pressure one time in the emergency room because they didn't know how to do it. They're like, I don't know what's going on, and I was like, well, you need a Doppler for that. Their EKGs are really wild. That one was another really cool EKG that I've done. Felt bad for the guy because he was getting zapped by his ICD because he went into VFib.
Are they in a normal sinus rhythm? Is that a normal LVAD EKG?
Yeah, so you'll see like it looks like VFib, but then you'll see like the QRS complexes when it so like it's still moving, but you can still, the machine is also causing all that artifact. Yeah. But there was one time where I was like doing the EKG on an LVAD patient, and then all of a sudden went into VFib, and I was like, oh. And then I see the ICD, and I was like, I'm so sorry, you're going to get shocked. And then he got shocked like 6 or 7 times.
Wow.
Huh.
But
that's pretty cool.
I got the VFib on record.
And you didn't get shocked yourself.
No, I as soon as I was like, well, you're gonna get zapped. So that one was really cool as well.
Well, we need to get Cheyenne out of here soonish. Anything else you guys wanted to talk about today or wanted to bring up while I have you?
No. Yeah.
I would say if you want to try to get into the medical field, try EMT, try EKGs. I think it's a great way for the younger audience or the younger generation to see if this is what you really want to do for an inpatient perspective. If you're a little bit more hesitant about those kind of things with the inpatient world, try outpatient. It's a little bit more low-key. I highly encourage people that might even not really passionate about this, but has like a small sense of like, want to give it a shot. Give it a try, because you learn not only a lot about yourself, you learn about what people you see out there, what the real world is like, right? Not everything is black and white. It's all gray, right? There's all sorts of different things that you have to try to incorporate, and I think that's what helped me kind of see the world, right? It's a good way to see like all these different types of people out there, not only patient-wise, but like staff-wise. You get to see doctors, you get to see nurses, you get to see paramedics, EMTs, right?
Even scribing is a good start well. Too. You do build that really close relationship with doctors and
I think that's a great way. And I think that's a great way to kind of introduce yourself, whether if you really want to go up, if you want to be a PA, if you want to be an MP.
On the flip side, you do see patients, but a lot of the time is also charting. So that is a good exposure to what medicine is like too.
Yeah, it's a good point, because I think sometimes you can go, if you go all the way through medical school and you don't really have much patient interaction, you might realize that being a doctor is really not what you thought it was. Yeah. If you don't see, we spend a lot of time at the computer. Yeah. I mean, sometimes the minority of our time is spent at the patient's bedside interacting with them, because I need to go verify everything they told me. I need to actually look at their history and look at all the tests they've had done in the past, because the patients don't often remember. They don't know what stuff to emphasize. So a lot of times it's spent, looking over their chart. And I think a lot of these roles are great introductions to medicine, because maybe you decide this really is not what you want to do, and this is not what you want to do for a career. And it's hard if you go all the way through medical school or even go to PA school with limited experience. It may not be the job that you thought it was. And so, I mean, that's what EMT was for me. I thought I wanted to be a doctor, and maybe I would have if I had, been stronger in college, right in my early 20s. But I was like, I can't go to school for that long. This is really hard. I can't work and do college. This is impossible. And somebody was like, oh, go get your EMT. And I didn't even know what an EMT was. And I was like, half, a full semester. I can go do half a semester. And then I was like, oh gosh, emergency medicine is what I want to keep doing, But some people go to EMT school and they're like, I cannot do this. I cannot handle the stuff that you have to see and the patients you have to deal with.
I do have a couple of friends like that already.
And it's hard if you commit to
the fact
this
is
long
that
education first.
You have tried it.
Yeah.
And I think a lot of the times out there that are not in the healthcare field, they have this idea of what it is because at the end of the day, they only have a patient's perspective. Right. So at least they have tried it out. They've got a general, and I think that's another thing with our generation is like no one wants to try anything out because everything is like everyone is, you got social media that kind of tells you what happens, right? And that's what you're basing it off of. And I think the only way to kind of experience these things or truly know is to actually be out there in the field. Yeah. Right. And I think doing stuff like this, telling people like what it's like out there, or seeing like the social media aspect of things it gives a lot of the younger generation an idea of like this might be kind of interesting.
Yeah.
And it's a lot of fun. You learn a lot of things. You meet a lot of new people. I think it's great for our generation because our generation sucks. We're so hard to convince, so hard to talk to,
and we're very transient in careers too. I mean, people switch jobs when they can't make one work or there's a little bit of strife or conflict at a job. They switch jobs.
It's all a money thing, and it is tough. It is tough because right now we do live in a world where like money is a big factor of whether if you make it or break it or if you stay in that position. I would just tell them just stick with it. There are other opportunities. That's why I like the healthcare field so much. Is because there are so many
broad.
Opportunities.
There's
so many opportunities, and the hospital they'll pay for it. They'll help you out because they want to keep you in. They want to make sure that you're successful, because not only that's good for you, that's good for their business as well, right? And they want to help you grow, and I think that's why I think people should be trying to dip their toes in it and try to see.
You never understand what something is really like unless you go through it yourself.
Exactly. I mean, for example, with like the scribes, right? Totally different areas, right? Totally. But the scribes see like the healthcare field, and I've seen scribes that
we see it in a like
EMTs or become
in a physician kind of perspective. Even though we're not allowed to perform physical exams, we do a lot of the charting. We do have to look at test results. We do have to analyze the test results, and then we just have to discuss with the physician like what they want in their notes. Yeah.
Cool. Well, thank you guys for your time. I appreciate you coming in. I think people get a lot of value from this and a different perspective than a lot of times we get here. So appreciate you guys.
Yeah, thank you.
Thanks
guys. I want to thank you guys again for your time. It's really important to see the ED from your perspectives to help us truly be a team and understand how we can support each other. It's easy to focus on the most visible roles in medicine, but it's the teamwork, the front desk, all the way to the trauma bay that keeps the whole system moving. If you're listening and you've ever been to the ER, remember this. Someone checked you in, someone ran that EKG, someone documented your story so the doctor could treat you, and all of that matters. All the roles are critical, and all are part of the emergency department team. If you enjoyed this conversation, subscribe to Practical EMS, give us a 5-star review, and check us out on social media. Share it with someone who needs to hear it, and we will see you guys next time.